So the known risk factors for type 1 diabetes are a genetic predisposition, and that is paired with a family history. So if you have no family history of type 1 diabetes, your risk in the United States is about 1 in 300, 1 in 400. But if you have a family member with type 1 diabetes, and specifically a first-degree relative, meaning a parent, a sibling, or a child with type 1 diabetes, that risk increases to 1 in 20. So we know there's a genetic component. What I will say about that is not everybody who has high genetic risk moves forward to a diagnosis of type 1 diabetes. In fact, even people with the highest genetic risk, 95% of the time are not diagnosed. So genetics are part of the question. The second part is some type of environmental trigger, and we've been investing in a lot of research to figure out what that is. So type 1 diabetes risk is a combination between genetics and environment, like many autoimmune conditions. What are the challenges at diagnosis? Well, the biggest challenge right now in the United States and globally is a condition or a complication at diagnosis called diabetic ketoacidosis. So many children and adolescents are diagnosed in an emergency situation where they require hospitalization, often in the ICU. And we know that our screening efforts and monitoring efforts can reduce that risk. And then finally, I would just add that living day to day with type 1 diabetes carries with it risk. You have to take insulin multiple times a day, which we know can cause severe low glucose levels that have to be addressed immediately. We also know that very high levels can result in an acute crisis. And finally, very high blood sugars or glucose levels over time can result in chronic complications. So we want to get to prevention and cure because it's a hard condition to manage in the day-to-day, and it's also leaves you at risk for complications over the long term. It's the title of the document is a mouthful, but here's the bottom line. For 40 years, we've been investing in research looking for something in the blood called an autoantibody, a type 1 diabetes autoantibody. And this allows us to identify people early before they require insulin. And we recently had the approval of a drug that allows us, if we get to people early, to delay the onset of type 1 diabetes on average 2 years. And we've got a lot of other therapies in the pipeline. And again, our goal is to delay it further and then ultimately prevent it. What was the document about? Well, there has been a push internationally to introduce screening for type 1 diabetes in the general population. 9 out of 10 times, people have no family history. And we want to catch it before symptoms develop, but when we do, there hasn't been any guidance on how to care for these individuals who are identified in these early stages. We know that early detection is important to prevent decay at diagnosis, and this guidance allows people to better support families, not just medically, but also in terms of the education provided and psychologically, so that the transition to treatment is less stressful. And then again, early detection identifies people who are eligible for these clinical trials. I can think of 6 off the top of my head that are recruiting right now that are testing these immune therapies and show promise in slowing down type 1 diabetes progression. And we've got an approved therapy in the US. The bottom line is that there was very little information on how best to care for these people in early stage type 1 and what the role of the different health providers should be in this process. If you're in primary care, if you're in specialty care, who does the work and how do we do it? So the consensus document fills that gap. This document helps people, real life people in clinics, so doctors, nurse practitioners, nurses, dietitians, psychologists, educators, in a very practical way, because drawing on the very best evidence we have available, it outlines clinical advice points that can immediately be operationalized in the clinical setting. It's not theoretical. It's very clear about how you would care for example, a child under 3, a child 3 to 9, or a child 9 years old or greater. It has specific data and evidence for how to care for adults with graded recommendations. And then finally, again, it shares the appropriate education, the cadence at which that education should be provided, and then encourages healthcare professionals to assess people's psychological well-being. It's a lot to carry, knowing that you're at risk for something, but you don't require insulin yet. So it's sort of a waiting game for the person. This guidance also, for the first time, provides clear advice on how to assess for any psychological concerns and then get people the help they need. So it's, again, a very practical advice for people in clinical practice right now. And it's available at no cost, open access online.